So this is an 18-year-old patient of mine with that had adolescent idiopathic scoliosis. I was supposed to operate on her probably about a year and a half ago, but they elected to hold off, and then the whole COVID thing happened, and then so she came back to have surgery with me. But this is obviously a double major curve, pretty complex. So we staged this over the course of 2 days. Can you go to that next slide? So then this, she obviously has flat back, both in terms of loss of normal lumbar lordosis and loss of normal thoracic kyphosis. And then can you go back to probably the third slide? One up there. So the first stage was a multi-level lateral procedure. And it's hard to see, but as Bob mentioned, the three lumbar interbody cages is the Amplify Surgical's Dual X. And if you take a look at this is the patient standing up, actually, on post-op day number 1 after her first stage. And you can see that if you sort of close your eyes and just look at with one eye and look below like L2, it looks straight, So the advent of these expandable cage technologies is really helping MIS surgeons like me and open surgeons alike to really correct the deformity. And it's a little bit difficult to see, but we also did a mini thoracotomy on the right and did 3-level laterals from T7 down to T10. And you can see that you don't get as much correction there, but what we've done is we've released what's tight on the concavity and maintained what's loose on the convexity as much as possible. And so this is similar to the growing rod concept, where you attack the apex and try to get some correction. And then in this case, all the other levels where we couldn't get an interbody, we actually do posterolateral facet fusions. And then can you then go back to the first slide again, Lee? And so this is the result that we get. So the second stage, we did T-lifts at levels where we could not access it safely, notably at L1-2 and then L5-S1. And we asymmetrically place these expandable cages, and they're the amplified dual X T-PLIF cages in this case. And you can see that we get great correction of the scoliosis, especially where it's collapsed at the concavity, at the major curve in the lumbar spine at L1-2, as well as at the lumbosacral fractional curve at L5-S1. And then we do a percutaneous technique from T6 down to the sacrum, and we can go down to the pelvis as well, but I really haven't found a need because of the fact that we have these large A-lift footprint cages now. So, and then can you go back to that last slide, Lee? So this is the type of coronal balance that we can get, correction. And this is the type of sagittal correction we can get. She had very flat back, right? But then now, with the advent of these expandable cages, we're able to reconstruct her spine both in the coronal, sagittal, as well as axial planes in order to get the type of correction that we need. And we're able to do this percutaneously. Believe it or not, the patient had the first stage on Monday, she had the second stage on Wednesday, and she's going home today. So this was not possible before. There's just no way that a patient would be ready for home that quickly. And it's not because of what we do, it's just the technique. So what we've done here is Dr. Price and I have sort of laid out the game plan. This part of it's essential. Like if you don't do this part, you're never going to be able to do anything percutaneously. So this part of it is absolutely critical. What we've done is we've drawn out the mid-sagittal line. Then we've drawn out 2 lines just lateral to the pedicle shadows. Up in the upper lumbar as well as in the thoracic. It's just right at that border of the pedicle. And as we go more caudal, down by L5 and S1, it becomes about 1 centimeter or 2 lateral to those shadows. Because as you know, the natural positioning of the pedicle goes from the mid-sagittal plane to more of a coronal-based. And so this is the kind of picture that you're going to want to see, is that you want all of these screws to sort of line up in a similar sagittal plane, but it's going to follow the patient's curvature. So if they had scoliosis, it would look something like this. But what you don't want is this kind of pattern. If you see this kind of pattern, you're going to have one hell of a day trying to get the rod down, and that's the very last step of this. So at every single step, we try to make sure that the guide wires are aligned, and then we take a look at the normal sort of the placement of the guide wires. So what we're going to do, we've already placed in the screws from L1 through S1 here on the left side. So Dr. Price is going to demonstrate using powered instruments to do this percutaneous technique. So if you can come up here, Tyler, and we'll start off with L1. So go ahead and picture that. And can you straighten that up and down, Tyler? Rotational, yeah, exactly.
Picture that.
So you're going to watch the angle also. Picture that.
Picture.
Picture. So you have to make these adjustments. Yeah, that's perfect. That looks great.
Picture.
Oh, hold on a second.
Nope.
Can you back it up a little bit? And then we're just kind of getting, we need to extend the skin incision just a little bit. Yeah, you got to turn this button this way. Try now. Okay, I'm just going to extend this incision just a little bit. Okay, go ahead.
Picture.
Go ahead. So essentially, he's just following this guide wire down. Yep. And we're going to get it to the same depth as the other screws.
Picture.
And the depth is really important here because of the fact that at every single level, what we're doing is we're positioning the screws to be parallel to the superior end plate at every single level. And the reason why that's important, and the starting point at every single level is also critical because of the fact that when you have the scoliosis in the coronal, axial, and sagittal planes, initially all of the guide wires they don't line up because of the deformity. When we make our correction at the very end, when we do the rotatory derotation maneuver, and then we do compression on the convexity and distraction on the concavity, what ends up happening is all of the guide wires then become parallel, and that's how I know we've gotten a good correction at the very end of the case.
Picture.
So essentially what Dr. Price is doing is he's following this guide wire down, and he's taking a look at the depth, and that looks perfect right there. And at every single level in between, we're also kind of taking a look at how these screws sort of are naturally lying in space, because we can't see the bottom of the tulip with our eyes. So we have to make sure this is the one we want to demonstrate.
Picture.
Because this one is actually out. And so when you see this picture, this is not a picture you want to see in a real patient. So we wanted to do this for demonstration purposes. The technique is you have to have good guide wire management here. Picture that. Picture. Picture. So I'm going to hold on to this, and I'm not going to allow this guide wire to go anteriorly, because that'll go into the retroperitoneal space, which you don't want, and you'll have a very long day. Okay, so if we get to this point, sometimes what we can do is we can disengage this. Can we see the chuck? Yeah. So why don't you unchuck that? Yep. So now what we can do is I can hold on to it here, and then Dr. Price is going to manually drive this down. Picture that? Okay, go ahead, picture that. Yep, go ahead.
Picture.
Looks good. And I'm making sure that this guide wire is not advancing anteriorly. This is critical.
Picture.
Better. Okay, so can I see a clamp? Hold on 1 second. I'm going to hold on to it with this clamp. Go ahead.
Picture.
Good. Are you capturing? Yeah, good.
Picture. Picture. Oops.
I think you have to push down a little harder.
Picture.
It's not capturing.
Feels like it.
Picture that.
There we go.
Now it's capturing.
Yeah.
Picture. Okay. Picture that. Good. Keep on going. And once it reaches the posterior vertebral body picture, then I can take the guide wire out. And then we can use power if you want.
Let's do it.
Okay, got it. Handheld. So then now I know that the tip of the screw is now within the vertebral body. As long as he maintains the same co-axis, it should go down that pathway that we formed before. So every single screw from L1 through L5 is parallel to the superior end plate. At L5, at S1, it's a little bit different. So the starting point for these guide wires is at the 3 o'clock and the 9 o'clock positions. But then down at S1, we're going to actually aim from the 4 o'clock and the 4 o'clock and the 8 o'clock positions and aim toward the sacral promontory. And we'll show you in just a little bit here.
Picture.
Watch your, yep, go ahead.
Picture.
Watch your angle. I think you're off.
Picture.
I think the screw's out also, or the guide wire's out.
Picture.
Yeah, I think the guide wire's out.
Picture. Picture.
Yeah, let's go back to an AP. Okay, so this guide wire's out, so you can pull everything out. And we're going to go back to the AP view and recannulate this pedicle here. And then can you cant it towards or just neutral, actually. So we're at L4, right? But that's probably going to be good right there. No, that's good right there. Picture that. And straighten that up and down. And I'll take a coker.
Picture.
Okay, let me pull this way. Go and picture that. There you go. There's a little shadow you can see, a white shadow in the pedicle. And so Rick's done a great job of actually finding that and just recannulating it.
Picture.
And it should fall right in there. Okay, picture that. So that was beautifully done. Go back to a lateral. That was masterful, doctor.
Thank you.
Okay. So then now back to the lateral again here. And then lower the C arm. Let's take a look at that. Good. That looks good. Firm endpoint. Yep. And you also typically I don't want the guide wire to be beyond the half of the vertebral body mark, because I don't like to take chances and break the anterior cortex unless I'm looking to put in bicortical screws. On that patient that I just showed you that we did this week, we did place in some bicortical screws. And in that instance, you've got to be very careful when you actually penetrate the anterior cortex. And we can do that at S1 here as well. I'll show you sort of the technique behind that.
X-ray.
That looks better right there, yep. Yep, watch the guide wire. Sorry. It did, okay. Okay, picture that. Go ahead. Picture.
One more.
That looks great. Did you feel like it went enter? Okay, if it did, picture that. Okay, you can loosen that and take a look. Picture that. Picture. Yep, by hand. So if you recognize that the anterior cortex has been violated, then you have to put it in by hand. And when you see that, we'll take control here. Hold on a second. Picture. Hold on a second. Let me clamp. Picture that. Okay, watch your angle. Picture. Picture. There you go. Go ahead. Picture that. Keep on going. Watch your angle. Picture. Better. That looks good. And I'll help you here. Picture. Picture. Okay, it's starting to advance anteriorly just a little bit, so I'm going to back this up just a little bit. Okay, picture that. Keep on going. Looks good. Picture.
X-ray.
That looks good. Okay, picture that. And that looks pretty good. So all of our screws are in on both sides now. Essentially, I'm going to bring the guide wire down to the bottom of the tulip, and I'm going to bring it down and then feed it across, okay? And then one thing that we do have to do is we need to create a little pocket. So we'll take, I usually do it with a bovie, but we can do it with a knife. And essentially, it depends on whether or not you're going to go from cranial to caudal to cranial. I'll take these rings out for the time being, and I'm going to create a little pocket, little fascial pocket, so that the holder and the rod have a place to sit there. And Dr. Price will do the same. So essentially, what we're going to do is we're going to bring this rod down to the bottom of the screw, and I'm going to bring it down like this. And essentially, then it's like kicking a field goal. We're going to go from one to the next screw, to the next screw, to the next screw, and I'm going to use this as a guide, because now I have rotational control of where this is going to go. In a case of scoliosis, let's say, for instance, the patient had a right apex scoli. It would look like this, right? So essentially, I would guide the rod like this, and then the derotation maneuver occurs like this, so that now I turn that scoliosis into a lumbar lordosis. Does that make sense? So essentially, what I'm going to do now is, you can take the rings off. I'm taking a look at the sagittal alignment of these screws, because I can already tell it's sort of doing this, which is a normal sagittal alignment. I'm a little worried with this picture here. See these screws here? S1, L5, L4, L3. It does a zigzag. So just as long as we recognize that, then it should be okay. But essentially what I'm going to do is I'm going to go down to this first screw, and then once I'm at the bottom, I'm going to bring my hand back like this and stay under the fascia, and then put it into this next screw, and then I look down to see if it's in there. And right now, when I turn it medially, nothing happens. When I turn it laterally, this screw moves. I don't know if you can see that or not. So see that? That moves, and so I know I'm medial to it. I'm going to back it up a little bit, and then guide it more laterally. And then now when I move this, the screw moves both ways, and I can actually see down. Picture that. Yeah, this may be a short rod. Picture. That one's longer.
X-ray. Yeah.
Go ahead, try it. Let's see if we can lock this down. Picture. Tighten. And then we turn this left apex scoliosis into a lumbar lordosis by doing that. Does that make sense, Bob? Okay, so what Rick is going to do is he's going down to the bottom of this, and then he's going to stay maintained. Yep. Just kind of have rotational control there. Yep. Just one at a time, and you know it's going to start going that way, right? So essentially, he's feeding the rod percutaneously under the fascia. Like, it literally is like trying to kick a field goal. So the tip of this rod is going through each of these screw heads right above the bottom of the tulip. And then he's watching it and he's feeling it. And essentially, you can get a sense of whether it's in or not with your visual sense, but also your ability to turn this rod left and right. If it's medial and it's touching the medial aspect of the screw, when you rotate it laterally, it's going to kick that screw out. But if you try to rotate it medially, nothing's going to happen. So that's how you can sort of confirm with tactile sensation whether or not you're in all of these screw heads. And we kind of figured this, but this part down here is going to be pretty challenging because of the fact that, as I mentioned, the 4 of the screws were sort of in a zigzag pattern, and that can be very challenging. But are they in?
Feels like it.
Nice. Okay. And then you're going to feed it through, get it through that, and then bring it back, and then seat it down. Okay. Nice work. So essentially, at this step, Bob, then we put the set screws in, and then we would actually turn this from a scoliotic curve and rotate it into a lordotic curve, if that makes sense. Yeah, I think so. I think that's a good idea, Bob. Any other questions?
Some tricky anatomy. Today we had a tricky anatomy. He was like, this is tough, but he showed me what experience in the vascular.
Yeah, you keep on putting the set screws. Does somebody have a question?
Are you doing mostly radio?
Why don't you start there and I'll start here.
My prior program never did radio.
Then you would reduce that anterolithes segment to the rod by that 2 centimeter distance that you've created between your fixed rod and the bottom of the tulip of L5. So that's a really, really useful. And this is a thing, like you'll see this pattern actually in scoliosis where it kind of goes back and forth a little bit. This one does a little bit too much of a zigzag. But essentially, at the end of the day, you know, we've sort of provisionally fixed these. And essentially, when you final tighten, essentially, why don't you final tighten this one first?
Okay. Want to derotate?
Yep. Now I'm doing the derotation. Go ahead. And as far as the axial deformity, so why don't you loose? You can reduce sort of rotatory deformity by bringing this over here into the same sagittal plane. So go ahead. Correct. Exactly. So every single level, I try to get an inner body, and again, the expandable technology that's available today is just incredible. And then the levels that I don't have any inner bodies, I'll do a facet fusion. Yeah. So we're really stressing these screws because they've done this. You know what I'm saying? Yeah. Why don't you tighten this one? Great. Yeah, I'm going to say something a little bit controversial. Like when I first started doing these talks and sort of promoting MIS scoliosis reconstruction, people were poo-pooing it, you know? And before I used to say that we could try to get at least equivalent results. Now I'm confident, I am absolutely confident that we can get superior results, both in terms of patient outcomes as well as correction of the scoliosis. I have no question in my mind about that. And also the SRS's own database of over 100,000 patients shows that the rate of infection in these patients with complex deformities, multi-level fusion surgeries, their risk of infection goes down 2 to 3x when you use minimally invasive techniques versus open techniques, you know? And so seeing someone like you, Bob, like really adopt and adhere to lateral techniques, minimally invasive techniques, percutaneous screws, I mean, that's amazing to me, to tell you quite honestly, right? Because it's up to us to make sure that we do the right thing for our patients, and that's the right thing. When we know that there are superior results from doing minimally invasive versus open, we should adopt those practices, try to learn them, and then try to teach the next generation of surgeons how to do these techniques. So thank you so much for giving us this opportunity to share these techniques with you, Bob. I really appreciate it.